Hi everyone, so welcome to my introductory tutorial on a hugely important topic, ST elevation MI, or STEMIs. I hope you enjoy and let's make a start. So these revision sessions are structured and easy to understand. They are designed for 3rd to 5th year clinical MBBS students on their clinical rotations, and they are ideal for clinical placement revision and for exams. They contain high-yield clinical medicine and summarize evidence-based guidelines in clinical management. I'm available outside of tutorials for contact in order to clarify any misunderstandings or anything that needs further discussion. Take a note of my email address and Instagram, and feel free to subscribe to my YouTube channel. So all information contained in this presentation or tutorial is for educational purposes only and should only be used by myself. This should not be used for the diagnosis or treatment of any health problem or disease. The information contained here is not intended to replace clinical judgment or to guide individual patient care. So let's start. We're looking at cardiology today and acute coronary syndromes. In the United Kingdom, 7.6 million people have cardiovascular disease, and it causes 27% of all deaths. There is one death every 3 minutes in the UK, costing the healthcare service a whopping £9 billion per year. Acute coronary syndromes encompass STEMIs, NSTEMIs, and unstable angina. We will be focusing on STEMIs. In unstable angina, you have no myocardial necrosis, and with NSTEMIs, you have an occluding thrombus, myocardial necrosis, and a rise in cardiac enzymes, but no ST elevation. So let's go on to a case. Mr. Khan is a 68-year-old gentleman who's presented to his emergency department with central pressing chest pain. He's tachycardic with a heart rate of 110. His blood pressure is 146/84. His respiratory rate is 26 breaths per minute, and his oxygen saturations are 96% on room air. He looks pale and diaphoretic. The nurse asks you to see him immediately as he looks unwell. What are your thoughts? On your initial review, on your primary survey, his airway is okay, his breathing sounds fine, his circulation is okay, he's oriented and alert, he's afebrile with a normal temperature, and he's slightly hyperglycemic. What would you like to happen next? It'd be a good idea to place an IV line, draw some blood tests, and do a 12-lead ECG. So now's a good time to take a history. What would you like to ask Mr. Khan? Well, you need an accurate pain assessment. So you could ask where the pain is, so site of pain, onset, what was the patient doing when the pain started, character, what does the pain feel like? R is for radiation. Does the pain go anywhere? Does it go to his left arm, to his right arm, up to his neck, to his jaw, through to his back? Does he have any associated symptoms such as nausea or vomiting or shortness of breath? T is for time. How long has he had the pain for? E, exacerbating or relieving factors. So does anything make it worse or make it better? And S is for severity. How bad is his pain? When you take a history from Mr. Khan, he says his pain started 30 minutes ago. It was radiating to his left shoulder. He's had shortness of breath with it. He's been clammy and diaphoretic since. Pain has been constant. He's had nothing has relieved it. He's felt nauseous and vomited once, and he's never had chest pain or seen a cardiologist in the past. He's got a past medical history of type 2 diabetes, hypertension, and high cholesterol. He's a smoker, 1 packet a day, doesn't drink alcohol, doesn't take drugs. There's no family history of note. You complete your examination by looking at his head, eyes, ENT, looking at his cardiorespiratory system, palpating his abdomen, doing a brief abdominal examination, checking his lower limbs and neurology, which are all normal. So what tests would you like to order? Well, it would be good to order a full blood count or a complete blood count, depending on where you are. Looking at his kidney function and electrolytes, so urea and electrolytes, or BUN, creatinine and basic metabolic panel. How you order these tests depends on where you're working. And a troponin, ideally a high sensitivity troponin. You've already requested the 12-lead ECG, and a chest X-ray has also been requested. So this is his ECG. Just take a second to look at it. What do you see? So there are some abnormalities that stand out. For example, in leads 2, 3, and AVF, you can see something going on. And then also in V2 and AVL. What treatment are you now going to give, Mr. Khan? Well, let's hold that thought before we commit an answer. When you're talking about STEMI, you need to be very familiar with the coronary artery supply at the heart. So as you know, there's a right coronary artery and a left coronary artery that supply different parts of the heart. Chest pain occurs due to an imbalance in the demand and supply of oxygen. So the demand is obviously going to increase if the heart tries to work harder. And that's why in angina sufferers, for example, as they exercise, they develop chest pain. And supply is going to be reduced with coronary artery occlusion. So if you have a blockage of one of those vessels. So relieving pain and anxiety is one of the key goals of management, because what you're doing is reducing the demand for oxygen. Anxiety can also cause a sympathetic overactivity. So when you have a blockage of the coronary arteries, you're going to have myocardial cell death. Cardiac enzymes are likely to be raised, and you may see ST segment elevation, and that will define a STEMI. So when a patient presents to the emergency department, you tend not to have cardiac enzymes available or results available. So you have the patient and you have an ECG. As you can see from the picture on the right-hand side, you have an atherosclerotic plaque, which grows over a number of years. It can rupture, and then a clot which forms can obstruct the coronary artery, leading to ischemia. Some of the symptoms and signs of a myocardial infarction include crushing substernal chest pain, which is not relieved by rest, diaphoresis or sweating, nausea, vomiting. The patient can be tachycardic or bradycardic, and they may be short of breath or dyspneic. So start simple measures early. Administer oxygen, maintaining oxygen saturations of above 94%, if that's appropriate. Consider reperfusion therapy early, which we will talk about. And consider GTN. GTN and nitroglycerin are the same thing. They are nitrates, but you would not give these in Mr. Khan, and we will talk about that shortly. Offer pain relief, for example, morphine, or diamorphine intravenously, and also give an antiemetic with that, which is metoclopramide, for example, 10 milligrams IV. You want to treat the pain and anxiety, as I mentioned. So there's some STEMI voltage criteria which you need to be familiar with. So this is a bit of learning which you just need to know. So you have a patient who's presented with clinical symptoms consistent with ACS, which is 20 or more minutes duration with persistent pain and ECG features in 2 or more contiguous leads. And the voltage criteria include 2.5 or more millimeters, which is more than 2.5 small squares, of ST elevation in leads V2 to V3 in men under 40 years of age, or 2 or more millimeters of ST elevation in V2, V3 in men over 40 years. 1.5 millimeters or more of ST elevation in V2 to V3 in women, and 1 or more millimeters of ST elevation in other leads, or new left bundle branch block, along with the clinical presentation. So this is a different ECG. As you can see, there is elevation in V1, V2, V3, V4, V5, and some in V6. Here you'd be considering an extensive anterior myocardial infarction, which is likely to be obstructing the left anterior descending artery. So to treat this, you would again give oxygen therapy as required. You could give morphine or diamorphine here. You could give nitrates as well, for example, GTN, an antiemetic, and ideally coronary reperfusion, which we're going to talk about. This is an anterior MI of the LAD, which is going to be affecting the anterior wall of the heart. Know the territory. So when you look at an ECG and you see ST elevations, what territory do they fit? So for example, we just saw an ECG where there's elevations in V1, V2, V3, V4, and some in V5 and V6. And that signifies a significant occlusion of the left coronary artery. If you had elevations in 2, 3, and AVF, you'd be thinking of an inferior STEMI. So this is Mr. Khan's 12-lead ECG. Now what do you think? So you can see some elevations in 2, 3, in AVF, and you can see some reciprocal changes in AVL and V2. So looking at this map up on the right-hand side, it fits with an inferior MI. As you can see, leads 2, leads 3, and leads AVF. As we said, with an inferior MI, inferior STEMI, avoid nitrates and avoid opiates, because what these are going to do is reduce the preload. These patients are preload dependent. So if you remember, the inferior wall of the heart is supplied by the right coronary artery, and that is the right ventricle. If you knock out your right ventricle, then these patients are going to be preload dependent. And giving them nitrates or opiates is only going to reduce their preload and could lead to a cardiac arrest. Beta blockers are shown to reduce mortality, and atenolol, for example, can be given PO, or it could be given intravenously, and bisoprolol can be given PO. Primary PCI is the aim for STEMIs. And primary PCI consists of angioplasty or stenting, and that's without previous thrombolysis. It's the favored approach, and it is superior to thrombolysis. There's better short-term mortality, reduced reinfarction rates, and a reduced incidence of stroke when compared to thrombolysis. So what should the door to balloon time be? And that means the minute the patient hits the door of the emergency department to the time when the angioplasty and stenting is done. So when the wire passes the occlusion. So benefit of PCI may become a harm when 1 to 2 hours have lapsed. So the ideal door to balloon time is 90 minutes. But patients within 2 hours can have a PCI. As I said, it is the door to balloon time is defined as the arrival to the ED to when the catheter guide wire crosses the lesion. And this is often inserted via the radial artery or the femoral artery by interventional cardiology. In the United Kingdom, for example, 95% of STEMIs are suitable for PCI because they arrive within the window. PCI is preferred in cardiogenic shock, and that's irrespective of what time the patient's symptoms started. If we look at thrombolysis, this is preferred if PCI is not available within 2 hours of first medical contact. So if a patient arrives to the emergency department and PCI cannot be done within 2 hours, then the patient may be amenable to thrombolysis. So priority is always reperfusion, but as you can see, there is a non-linear relationship between treatment delay and outcome. So the longer you wait for treatment, the outcome is going to become less favorable. With thrombolysis, there are 60 deaths per 1,000 prevented if given within 1 hour of symptoms. So what this means is if you give thrombolysis within 1 hour of the patient presenting with their symptoms, you're preventing 60 deaths per 1,000. And evidence suggests that pre-hospital thrombolysis saves lives, and thrombolysis is being administered by paramedics safely in the community in the United Kingdom. And agents of use include, for example, tenecteplase or alteplase, and these tend to be given with aspirin and clopidogrel and low molecular weight heparin. There are some risks to thrombolysis. Hemorrhage, for example. So hemorrhage, the risk of hemorrhage is more than 3.9 per 1,000 patients treated. And the maximum risk is within 24 hours of treatment. Other risk factors include females, older patients, patients with lower body weight, and those with hypertension. Age is not a contraindication to thrombolysis. And again, there is a parameter that you aim for, which is a door to needle time of less than 30 minutes. So that is when the patient hits the door of the emergency department to the time you administer the thrombolytic. You do need to know about the absolute contraindications to thrombolysis, and these include a hemorrhagic stroke, and that's any history of a hemorrhagic stroke at any time in a patient's life, ischemic stroke within 6 months, surgery which has occurred within 3 weeks, recent major trauma or head injury, GI bleeding within the past month, a patient has an aortic dissection, a known bleeding disorder, or a neurological deficit or CNS neoplasm. Relative contraindications include warfarin therapy, pregnancy or the immediate postpartum period, a mini stroke or TIA in the last 6 months, prolonged or traumatic resuscitation, a systolic blood pressure of over 180, active peptic ulcer disease or advanced hepatic disease, a non-compressible puncture site or infective endocarditis. With thrombolysis, you can have there is a risk of failure to perfuse, which means you administer the thrombolytic and you don't manage to perfuse. And that is defined as a lack of resolution of more than 50% of the ST elevation after 90 minutes. It can occur in up to a third of patients who receives thrombolysis, and then they are referred for rescue PCI, which means they have received the thrombolysis, and then they are sent to interventional cardiology to have a PCI done. Even if a patient has a successful thrombolysis, the patients should get pre-discharge angiography, and that's within 6 to 24 hours. As we mentioned, warfarin is a relative contraindication. However, there is no evidence base on whether or not to thrombolyze. So with these patients, you have to balance risk and benefits and obtain an urgent INR. So for example, if the patient is subtherapeutic with an INR of less than 2, you may consider thrombolysis, whereas if it was above 3, you wouldn't. Between 2 and 3, you'd really have to weigh the risks and benefits of thrombolysis and the possible increased risk of bleeding. So there's some adjuvant therapy. Aspirin can be given at a dose of between 150 to 325 milligrams orally, and that's the STAT dose, which is continued at 75 to 150 milligrams daily. It irreversibly acetylates platelet cyclooxygenase and inhibits platelet aggregation. It also has some indirect antithrombotic effects, and it is the most cost-effective treatment in acute MI. It can be administered early and should be administered early if no allergy or GI bleeding. Clopidogrel is also an antiplatelet, and it promotes platelet CAMP formation, reducing platelet calcium and aggregation. It also affects the G2B3A receptor transformation and reduces aggregation. Prasugrel is an oral antiplatelet similar to clopidogrel. It's faster acting, and it can be used with aspirin instead of clopidogrel in STEMI patients receiving PCI. Ticagrelor is an antiplatelet, an antagonist to P2Y12 ADP receptor. It's given with aspirin and can be used alongside aspirin as an alternative to clopidogrel in STEMI patients receiving a PCI. Heparin is also administered. Unfractionated heparin inhibits clot formation. It prevents fibrinogen to fibrin. And a comparison of unfractionated heparin and low molecular weight heparin in STEMI patients who received thrombolysis found that there was an improved outcome at day 30 in the enoxaparin or low molecular weight heparin group. Fondaparinux is a selective factor Xa inhibitor, and it has been evaluated in the setting of STEMI with reduced mortality and reduced reinfarction rate. It's indicated in patients managed with thrombolytics. It's not indicated for patients who've had a PCI, has a long half-life, and there's a once daily dosing. GP2B3A inhibitors have been shown to have no improved outcomes in adjuvant therapy with thrombolysis in STEMI, and there's no role in routine practice. So a brief word on STEMI complications. There are quite a few of these, but in summary, a patient may have left ventricular failure, and with this, they will have signs and symptoms of pulmonary edema, including dyspnea, hypoxia, tachycardia. You may hear a third heart sound and crackles. You may see pulmonary edema on the chest X-ray. An echocardiogram should be done. And treatment consists of diuretics, nitrates, possible NIV or CPAP, and ACE inhibitors. Cardiogenic shock is usually from an extensive anterior MI or with left bundle branch block, and is due to left ventricular dysfunction where a large proportion of the cardiac muscle has infarcted. It causes hypoperfusion, so the blood pressure will be low. The patient will be tachycardic with a prolonged cap refill time and reduced urinary output. These patients may require intra-aortic balloon pump insertion and inotropes, and will require cardiac intensive care. Right ventricular dysfunction. So this can occur with inferior MIs like our patient, Mr. Khan. They could have hypotension and distended neck veins with extensive right ventricular infarction. They're not going to have pulmonary edema, and you should do right-sided chest leads to confirm the ST elevation. It is vital to maintain right ventricular preload, so avoid any therapy that is going to reduce preload, and that includes nitrates and opiates. And you can give a fluid challenge. Mitral regurgitation can occur after a STEMI. It's the most common mechanical complication. It leads to acute cardiac failure, pulmonary edema, and hypotension, and is due to rupture of the chordae tendineae, or papillary muscle infarction and rupture. It can be due to dilatation of the mitral valve ring as a result of left ventricular dilatation. You may hear a new murmur. An echocardiogram is confirmative, and these patients require surgery. Ventricular septal defects can occur with an anterior or posterior acute MI. Similar to mitral regurgitation symptoms, an echocardiogram can be done and urgent surgery for repair. A cardiac rupture or tamponade is often fatal, can cause sudden death. It's more common in the elderly, and these patients are likely to have Beck's triad, which includes hypotension, so low blood pressure, distended neck veins, and muffled heart sounds. An echocardiogram should be confirmative, and these patients can receive a pericardiocentesis, but ultimately are going to require surgical intervention. There are also a number of arrhythmias which are associated with STEMIs, which you need to be aware about, which include the broad complex tachyarrhythmias, such as ventricular tachycardia and ventricular fibrillation. So for most STEMI patients, you will want to give them oxygen therapy and pain relief, such as morphine, an antiemetic intravenously, aspirin at, for example, 300 milligrams orally, either clopidogrel 300 milligrams or ticagrelor 180 milligrams, depending on the preference of your cardiologist, and heparin intravenously, or low molecular weight heparin, and then primary PCI. And this is for the non-inferior MIs. Obviously, as I have emphasized with the inferior MIs, you don't want to give morphine. And on this list, you would also give patients nitrates, such as GTN. So remember that this lecture was for education only, and evidence is evolving. You should stay up to date, consult your local guidelines, and time is heart muscle. In this depiction on the left, you can see that there is an evolution to an ST elevation MI, which you need to be aware about, because you could capture a STEMI at any phase of its evolution. Be aware of regional ST elevation ECG findings. So, for example, with an inferior MI, you may get elevation in 2, 3, and AVF, which is due to blockage of the right coronary artery, and you would be anticipating a right ventricular or posterior infarct. An anterior MI, which will show you will have elevations in V3 or V4 and V4. This will primarily affect your left anterior descending artery and can cause complete heart block, left ventricular dysfunction, and bundle branch block. A septal STEMI will affect V1 and V2, again affecting the left anterior descending, and you could get bundle branch block with this. A lateral STEMI will affect V5, V6, lead 1, and AVL, and this is due to a blockage of your left circumflex artery. Anticipate left ventricular dysfunction as well, with possible congestive heart failure. You can do right ventricular leads, which include V4 and V4R, and they will show possible ST elevation due to a right coronary artery occlusion. You may get hypotension, but clear lungs. And remember that these patients with a right ventricular infarction, i.e. inferior STEMI, may be preload dependent. So avoid nitrates and potentially opiates. Posterior MIs, you can do posterior leads with V7 to V9, and you may find ST depressions in V1 and V2. So remember, ECG interpretation is very important. Know your territories as well. A brief word before we finish on serum markers. So troponin I is the most sensitive or specific. There's a delayed rise, so it tends to rise within 3 to 6 hours after symptom onset. However, there are highly sensitive assays currently available, which may rise in 2 to 3 hours. A troponin tends to peak at 12 to 24 hours, and it normalizes within 7 to 10 days. Unlike troponin T, it is not elevated in skeletal muscle disease. Other cardiac markers include myoglobin, which has poor specificity, and CKMB, which is not as sensitive or specific as troponin. So thank you very much. My name is Dr. Bhatti. I'm a consultant in emergency medicine. This was the introductory tutorial to clinical medicine, where we discussed briefly STEMI management. Please subscribe to my YouTube channel and contact me further if you'd like further tutorials.